Hi, everyone, and welcome to this other session of the Cameroon Town Hall for Healthcare Professionals. This is the 107th session of the town hall. It's really amazing to know that this town hall has had over 100 sessions, really to discuss very important public health, global health, and clinical subjects, particularly the ones that are pertinent and relevant to Cameroon, and bringing together people from the diaspora to discuss some really critical subjects. The last session of the town hall was scheduled for an interaction with the Minister of Health. He was scheduled to discuss on some of the progress. He had spoken before on what the ministry is doing in terms of universal health coverage, and he had given us some sort of an idea of what his vision was for the Ministry of Health in terms of what to include in the package for universal health coverage, which was kind of great. So I think there's been significant progress and updates, and it was his desire to share some of those updates with us. But unfortunately, he's not able to join us today. You all might be aware that we are currently facing a major public health emergency. The World Health Organization last week, Wednesday, declared the Mpox situation in Africa to be a public health emergency of international concern. And the Tuesday prior, the Africa CDC declared the very first ever public health emergency of continental concern. So it is very clear that the continent is facing a very serious threat. And we are not very surprised to hear about these issues around zoonotic spillovers. This are very likely to continue to happen. But His Excellency is very occupied with that response efforts. As you all may know, Cameroon is very unique in the sense that it's the only country where both clades of the Mpox virus have been detected. So we are almost at the epicenter of where R&D, research and development, should be centered. So we thought that it would be great for us to use this session to have an open discussion on the current state of the Mpox outbreak in Africa, but also discuss some of the things that Cameroon is doing. So we will have this session to be more of an open dialogue. We want to have a sense of what your perception is in terms of lessons that were learned during the last 4 years of the COVID-19 pandemic, and how those lessons can be implemented during this COVID-19. Have we learned any lessons from what happened during the COVID-19 pandemic? Do we have any signs that we've actually learned from the COVID-19 pandemic? And are there some lessons from that experience that we could transfer in our response efforts towards the Mpox situation in Africa? So we would love to open this floor for inputs in terms of what Cameroon can do better, what Cameroon and Africa in general can do better. What are some central questions that we don't have answers to that we should be investigating? What are some things that we know, and what are some things that we don't know? What are some important strategic directions that we should be taking? So I'm really honored today to co-moderate today with our chair, Dr. Mona. I think Elvis Ndansi is going to join us in a bit. And I also want to welcome Dr. Matt Sandra Polo. And thanks a lot. I just learned from Dr. Mona just earlier, a few minutes ago, that you'll be joining the moderation team. So thanks a lot also for your dedication. So I'm looking forward to Dr. Mona, I'm looking forward to an exciting conversation. I'm really hoping to gain a lot and maybe get some inputs that could potentially be helpful for our response strategy in Cameroon. So yeah, welcome everyone, and welcome to the chair, Dr. Mono.
Wow, Brian, thank you very much. And thank you for your dedication to the town hall and for being up to date and getting us this very important topic that we are going to talk about. As being part of, I have a lot of questions. I think my part will be at a certain point, I will pose some questions to you just for us to see exactly where we are so that we can easily guide this discussion when it comes to Mpox. So I do have a lot of questions that I will want you to give me your answer. I know you've been doing a lot of work in the CDC concerning COVID, concerning gene sequencing, concerning preparing us for future pandemics and preparing us for future epidemics that can happen. So this is one of the things that I think you are one of those who is super knowledgeable about this topic. So I would love to get your input. I would like to, before we go forward, maybe give a word to Dr. Polo for joining our moderating team. And here today is just going to be an open discussion. We want to know from everyone what they think about what Africa can do better in order to prevent future situations like this. So, Dr. Sandrine, you have the floor.
Yes, thank you, Dr. Mono. Good afternoon, good evening to everyone. Thank you, Brian. I'm really pleased to be joining and helping to moderate this session or the next. So today it's a very important topic. I'm really looking forward for Brian to actually share with us what is it that we should do with the gene sequencing, but more importantly, what can we do, practically speaking, in terms of protecting our population in Africa. As we know, the the viral therapy which is available to treat this disease is not widely available in Africa. So I really looking forward to see what is available for African population and any population, quite frankly, with no access to the latest therapy, particularly the viral therapy for this disease. So, thank you. And je pourrais aussi parler en français. C'est aussi la raison pour laquelle j'ai ce plaisir de participer à la modération de cette session. Donc, aujourd'hui, Brian va parler de la variole simienne, donc Mpox, et introduire un peu ce qu'on pourrait faire au niveau du séquençage, donc comprendre un peu les souches virales qui sont impliquées dans cette maladie, particulièrement en Afrique. Et personnellement, je serais intéressée aussi à explorer qu'est-ce qu'on peut faire pratiquement pour l'accès au traitement en Afrique pour cette maladie-là, compte tenu du fait qu'on n'a pas l'accès aux thérapies antivirales comme ça l'est dans des pays un peu plus développés. Donc, ce serait intéressant d'entendre le point de vue de chacun de nous. Merci.
Yeah, so Brian, I think we're going to have a conversation, which I would love it to. In the first place, there are a lot of people here whom Sandrine and I will have some questions too, and the rest of the public. I just want to ask questions. I don't want us to make it in a presentation mode. What is monkeypox in the first place, Brian? And this can go to others too. I just want to know, like, what is monkeypox? Is it a new disease?
Yeah, Mono, thanks a lot. I would wanna, I just dropped the link in the chat. Myself and Dr. Bogomati Tanji and some ID physicians in the US were invited by one of the sub-journals for the Infectious Disease Society of America to write a contemporary review on Mpox during the 2022 search of the Mpox outbreak, which eventually became the editor's choice, and we really been widely cited. And very grateful for that. So I really would encourage everyone to have a chance to look through. I think the discussions we had then is still very relevant to what's happening today. It's important to note that the current surge that's happening in Africa is very the strain is distinct from the strain that we saw in 2022. The 2022 outbreak was primarily driven by monkeypox virus 2. The name was changed from monkeypox due to stigmatization and issues around that. The name was changed to Mpox from monkeypox. So we're referring to this as Mpox. So there are two main clades, as we would like to describe them. There's the clade 1 and clade 2. Clade 1 is predominant in the Central African region. That's where it's mostly identified. The current surge in the DRC and the Central African region is predominantly clade 1. Clade 2 is predominant in the West African region, and that's what led to the surge in the Mpox cases in 2022. One of the distinct characteristics of the viral isolates that were sequenced during the 2022 outbreak was the accumulation of a very, very specific mutation called the Appleback mutation, which sort of enhanced the ability of the virus to get into the cell. So it sort of increased transmissibility. And epidemiologically, most of the cases clustered around the MSM community. So men will have sex with men. That was the driving epidemiological characteristics. And it led to a huge surge in response in terms of mobilization of resources. So you may have heard, Dr. Mono, there's just a lot of very quickly therapeutics were made available, vaccines was made available, etc. But no one really cared what Africa was facing at the time because we did not really have a huge surge in Mpox in Africa. We did not experience to the same degree as the US and other developed countries. So this current surge in 2024 is primarily driven by by a different clade. But they are very pertinent questions. And I think Dr. Polo highlighted some of those questions around therapeutics. I think whenever we have any surge in outbreak, we want to really primarily know the characteristics, what the epidemiological characteristics are, what the transmission dynamics are. And we want to know if we have countermeasures that are available to counterfact them. So I think Dr. Polo highlighted one of those, and one of those is really therapeutics. Do we have medications that can work? And I think she mentioned one of the antivirals. And I'm happy to talk about that specific antiviral. It's called tecovirimat, and there are others as well. Unfortunately, there was an NIH study that was published, that was released, report that was made available last week that showed that tecovirimat did not decrease, was safe, but did not decrease the time to symptom resolution in this very specific strain of Mpox. But it was very effective during the 2022 outbreak that we experienced in the US. So the question is, what has changed? Why is it not working in our context? So there are quite a few reasons, and myself and some people at the NIH are trying to explore some of those questions right now. The current hypothesis is the specific target, that specific drug, the specific drug target for that medication is a specific protein called the VP37 protein that's translated from a specific gene. So our hypothesis is that specific site has accumulated a lot of mutations. If you look at any phylogenetic tree from the sequences from Africa, you will notice that the branches are very divergent. I don't have it open on my screen now, but I would maybe I'll share later a phylogenetic tree to see what that looks like. But most of the branches are very divergent, and what that means is the virus has accumulated so much mutations that specific site has been altered. So the one hypothesis is maybe that's one reason why that specific medication is not as effective as it is. But again, we don't have a lot of data. It's very difficult to make conclusive statements without really having sufficient data. I think the sampling pool was very small. So we have lots of challenges in terms of implementing clinical trials in Africa. And this was just one of those glaring one of those glaring examples, Dr. Mono. So yeah, so I think that's pretty much each. Monkeypox is as you know, it's a zoonotic disease. It was initially identified in animals that were imported to Denmark in the 1958. These were monkeys. When the scientists at the time discovered that the monkeys just developed some pox-like lesions or rash, so that was when the virus was initially identified, and that's why it was named monkeypox, because it was really identified among those animals at the time. But between then and approximately 1972, there were really no cases. The very first case of Mpox actually occurred in 1972, and it was in a 9-year-old child. And those of you who were born after 1970, you might remember the smallpox eradication campaign. The World Health Organization declared the Mpox eradicated around that same time frame. So most of those who were born before that time probably received the vaccination against Mpox, which kind of conferred immunity against future against Mpox and other pox viruses in general. So I think not a lot of cases sort of occurred, but those who were not vaccinated were definitely immune. So we began to actually see cases of Mpox began to appear after shortly after 1972. That's when we began to have surge of cases. But most of those cases were really zoonotic spillovers. They were due to African parents going to the bush, eating meat, killing meat, and coming back home and cooking those meats. And so that exposure happened then, and that's how those kind of spillovers began to occur. So that's where monkeypox pretty much started from, Dr. Mono, and these events, zoonotic spillover events are very likely to happen because we are increasingly destroying the environment, deforestation. We are destroying the habitats of animals. So the distance between humans, the environment, and animals is becoming smaller and smaller. So the probability of viruses that normally habitate in animals to spill over into human hosts is increasing. So I think the greatest fear here is that these viruses would accumulate mutations that will make them more transmissible in human hosts. I think that's the biggest challenge. And I think from an epidemiological perspective, we need to build more robust One Health surveillance mechanisms. So we need to strengthen our ability to detect diseases much earlier, whether that is with testing, sequencing, etc. Because sequencing is very important because it really helps us to precisely know what changes are occurring within the genome of an organism and to be able to track those, and whether or not those mutations have implications against therapeutics, against vaccines, against diagnostics, the countermeasures that we do have. Do those mutations lead to more severe disease, severe outcomes, and things of that nature? So we definitely need surveillance at every front. So Dr. Mon, I'm going to end there, but that's I didn't plan to give any overview.
No, I know, Brian, and I happened, when I saw this, I wanted to contact my own very good friend, and I think who is one of the I'll call who has core knowledge on this topic. And you guys, you did put your seminal paper, which you published on this, and the editor's review. And I see there's Professor Boguma Titenje is here. So I would want to get a sense. I wanted to invite her later on for us to talk about this. This was a change in the last minute as the minister could not also make it because of still the Mpox. So I don't know if she's able to give us 1 or 2 words about what we should. This is an open discussion. That's how we really put it out there, and see if she can give us an insight into. I had a series of other questions for you, Brian, which are going to come later, both for you and Boguma. But I don't know if Boguma is in an environment where she can talk to give us an insight of what we should look for. And advocacy is very, very clear online. If those who want to see, if you're on LinkedIn, if you are on any other space in the social media, you would see that she's one of the biggest advocates for both infectious disease and also for Africa, and for us to be able to have equity health. And why don't we even have these vaccines ready to go? So I would ask if she's somewhere that she can unmute. If not, then we will
I was trying to go incognito. I'm using my middle name. What is your problem?
I can identify all your names. So.
No, I just logged in just to listen and maybe serve as a resource to answer questions, because I know there's a lot of misinformation online, and just, a lack of understanding regarding what is going on and why we're seeing this happen, and what does this mean in terms of whether this is going to become an outbreak on the scale of COVID. Are people going to see lockdowns? There's a lot of misinformation around that, because, of course, whenever you have an outbreak of an infectious disease, you have people who want to exploit the panic and the chaos that comes with outbreaks to basically try to push various agenda. I think that Brian gave a reasonable summary of the current situation in terms of why we're seeing these outbreaks now happen across Africa. I just want to add a couple of clarifying points. The first thing is in terms of thinking about why we saw an outbreak in 2022 and also what led to the outbreaks in 2022. I'll start from there and then I'll move on to where we are now. As Brian mentioned, the outbreaks in 2022 was really the first time that we were seeing sustained human-to-human transmission of Mpox outside of endemic countries in Africa without the need for zoonotic introduction. And that is really what led to the state of alarm, in the sense that normally this was a virus that is very well circumscribed and known to be endemic for clade 2 in West Africa and for clade 1 endemic in Central Africa. And in 2022, kind of in June, beginning in June, we started seeing cases prop up in countries in Europe, and they were primarily spreading through sexual networks of men who have sex with men, although transmission is not exclusively sexual. Transmission is through close contact, proximity with someone who has active lesions, and sex constitutes close contact. So it so happened that we saw a significant concentration in sexual networks in the summer of 2022. But when you look at the sequences of the virus that spread and caused the outbreak in 2022, the clade 2B virus, just to clarify the point that Brian was trying to make, when you look at the sequences of the virus and look at the clustering of how those viruses cluster compared to the outbreak that happened, the viruses from the outbreak that happened in Nigeria in 2017 and 2018, there is indeed something we call a signature, an accumulation of a signature of ApoBec C3 mutations. Now, ApoBec enzymes are enzymes that exist in mammalian cells, including our human cells, and they are DNA editing enzymes. When ApoBec edits the DNA of a virus, a viral pathogen, like a DNA virus, like monkeypox virus, what happens is you see specific nucleotide changes in the sequence of the virus that tells you that this virus has been edited by an ApoBec enzyme. So that is essentially what that means. And that accumulation simply tells us that that virus is spreading from human to human in a sustained manner, and our DNA editing enzymes are editing that virus. Now, we don't know whether the changes conferred by the evolution of the virus as it spreads from human to human have necessarily made it more efficient for human-to-human transmission. I think that it's very important to clarify that there's no evidence yet that has clearly demonstrated that the accumulation of those mutations makes this virus more infectious compared to whether the virus has simply found a way of exploiting a new mechanism of transmission through sexual contact and is able to spread in that manner. I think it's very important to clarify that. Now, in response to the outbreak in 2022, what happened was a lot of the big clustering of cases were primarily happening in North America and in European countries. And Africa had a much smaller outbreak during that time. We have smallpox vaccines that, or vaccines that were developed for smallpox. The one that was most extensively utilized in the 2022 outbreak was a third generation vaccine developed for smallpox. And this vaccine is based on vaccinia virus, which is also an orthopox virus. The thing about orthopox viruses is that they can confer cross immunity. This simply means that if you've been vaccinated for one orthopox virus, in this case, vaccinia, the immunity that you mount in response to being exposed to vaccinia will confer some degree of protection to other orthopox viruses. So we were able to use the vaccine that was available and had been stockpiled in the event of smallpox being reintroduced to quickly deploy it in countries that had access to those vaccines. And now we have evidence that indicates that after 2 doses of the modified vaccinia Ankara-based vaccine made by Bavarian Nordic, the degree of protection that you get against Mpox clade 2B is anywhere between 75% to about 85%. And there have been several clinical cohorts that have looked at this effectiveness. Now, I would caveat that with the fact that, remember, we saw these outbreaks happen in 2022. And we've only basically had 2 years follow-up since those outbreaks. So we can't fully comment on the durability of protection that these vaccines confer. We do know that there are individuals who were vaccinated in 2022 who have had post-vaccine reinfection with Mpox. Thankfully, those numbers remain low. And we also know that even in individuals who have had Mpox after being vaccinated with an MVA vaccine, they have tended to have milder disease. Now, fast forward to what's happening currently. The DRC has been having yearly outbreaks of Mpox pretty much since the 1970s. And the reason for that, and Brian alluded to that, is that effectively all smallpox vaccination ended around the globe by 1980. So anybody who is born after 1980 essentially didn't get a smallpox vaccination and doesn't have any vaccine-induced immunity against orthopox viruses. We have had a huge growth in the population in the 40 years since 1980, the 40 plus years since 1980. There's increased mobility of populations, and we have a large vulnerable population that doesn't have immunity to orthopox viruses. Viruses thrive on opportunity. And this has been why for several years, as we've progressively seen more frequent and larger outbreaks of Mpox happening in the DRC and sporadically in other countries in West Africa, there has always been a cry of what are we going to do to make these outbreaks happen less frequently? Because clearly there is a vulnerable population, and we are now seeing these viruses get introduced into urban centers, whereas previously, maybe when the outbreaks would happen through zoonotic transmission, it will be contained just by virtue of happening in a rural community, away from a city in a remote part of, say, the DRC or any other African country. In Nigeria in 2017 and 2018, it was introduced into an urban center. In 2023, they started seeing cases in large cities in the DRC. And again, they started seeing that they described again for the first time transmission through sexual networks. This was done and published kind of late towards last year. Again, opportunity, introduction into an urban center, effective transmission through close contact mediated through sex, that gives a virus opportunity when you have a vulnerable population that has no immunity. Now, what really raised the alarm in terms of the situation in the DRC currently is that multiple outbreaks were happening of clade 1 virus, but they also noted in a cluster of 241 individuals in an outbreak in a mining town in the DRC in the late of last year through to January of this year. They noted that the sequences that they obtained from that cluster again had that signature Mpox C3 mutation, indicative of the fact that you had sustained transmission of this virus in humans. And additionally, those sequences were quite divergent from previous sequences of clade 1 virus, and so divergent that they were basically indicative of a new strain of the virus, which they're now calling clade 1b. So the rise in case numbers, the exportation of cases now to 16 other African countries that are reporting outbreaks, and the fact that we are seeing the spread of clade 2, which has been associated with a higher level of mortality compared to, of clade 1, which has been associated with a higher level of mortality compared to clade 2, really triggered the alarm to get the WHO and the Africa CDC to say, we really need to tamp this down, and we have to think about strategies by which to effectively stop the spread of the virus. So I will stop there and hand it over to you, Muno.
Wow. I said always, it's a privilege having you in our circle. And I think Africa needs you more than you can imagine. In times like this, they've always needed you. And I don't know how much they value their own in such a way that I think with us getting into a situation like this, we need minds like yours in order to put us in the right track of protecting the future of Africa and the world overall. I have a few, like, as I said, this is a discussion. I just wanted to make it a discussion.
Please, Dr. Mono.
Here. Yes, please,
Please, Dr. Mono.
Yes, we'll follow up with, we'll open it.
No, it's not a question. I just want to, I don't know, I cannot connect with my PC. I don't know if other people are facing that issue. I don't know if it's a technical issue. Yeah, because I've been trying for the past 30 minutes and it's just saying that I should register. And when I register, it's still kicking me off. So I've been able to connect with my phone. I don't know if it's a technical issue or if it's just at my end. So I wonder, maybe you find out that maybe that's why some people are not connecting. I don't know.
Okay, thank you for that feedback.
I don't know if other people face that same issue. Yeah.
I am connected on my laptop.
Okay, thank you. So,
okay.
Yeah. I have a question when it comes to the vaccine, which we have right now. How do we know, based on the modified vaccinia that we have at the moment, how effective is the vaccine? I know you made allusion to that during your talk. And how affordable and how available is this vaccine during this pandemic? Do we actually have it in Africa? Is this something is it an advocacy that we have to join? And are there other research ongoing on developing new vaccines just specifically for Mpox?
Yes, so this is what I'm going to say. The effectiveness, the MVA-BN vaccine is a third generation vaccine. As I said, it was a vaccine that is based on modified vaccinia Ankara virus and was developed as part of preparedness for the eventuality of an outbreak from smallpox. Now, that particular vaccine was deployed during 2022 in the outbreaks which affected primarily global north countries, Europe and America. And over 10 million doses of that vaccine were administered. It was safe, it was immunogenic, and we were able to estimate the effectiveness against clade 2B to be anywhere between 75% to 85% protection. Even in instances where the vaccine wasn't fully protective against infection, if individuals got the infection, it still led to an attenuated course of disease. Now, turning over to its effectiveness against clade 1B, MVA-BN has been studied in phase 2 studies in health workers in the DRC, prior even to the outbreaks that we are seeing now. And we know that it was immunogenic in these health workers, created a robust response when it was deployed, comparable to what they have seen elsewhere. Now we don't have the data for effectiveness specifically against clade 1 A and B virus, because there's not a huge proportion of the population that has been vaccinated with it for us to then compare between vaccinees and unvaccinated, whether to gauge the degree of effectiveness. We do have data from older generation smallpox vaccines. So first generation Dryvax and second generation ACAM 2000. These were first and second generation vaccines for smallpox, again based on unattenuated replication competent vaccinia virus, which were used to finish the end of the smallpox eradication program. And there were retrospective studies conducted by the WHO in the DRC in the late 80s and up to the 1990s and 2000s, which retrospectively, in the context of Mpox outbreaks, looked at household contacts of people who were infected with Mpox and compared the incidence of Mpox amongst those who had a history of smallpox vaccination and those who did not have a history of smallpox vaccination. The first and second generation vaccines were also about 75 to 80% effective in preventing Mpox, and we're talking about clade 1. However, you cannot directly extrapolate the effectiveness of first and second generation vaccinia-based vaccines to the effectiveness of a third generation vaccine, which is based on a non-replicating virus, because a replicating vaccine, a replication competent vaccine, may modulate the immune response differently from a vaccine that is not replication competent. So there might be some slight differences in effectiveness in terms of the protective ability of the vaccine. Now, going back to what we know about orthopox viruses, and again, that cross-reactivity in terms of their ability to cause an immune response that is cross-protective within the species, it is expected that MVA-BN, the third generation vaccine, will confer a degree of protection against clade 1 virus. We don't know yet if it will be comparable to the degree of protection we saw with clade 2B, but it should confer a degree of protection. And even if it's not absolute protection, it should also reduce the severity of disease. Now, coming to the question of, are these vaccines available on the African continent? They were not available on the African continent, and there are many reasons. It's not just an advocacy issue. One, there was issues of countries in the global north stockpiling these vaccines and utilizing them in the outbreaks in 2022. But even despite the public health emergency of international concern for Mpox that was declared in 2022, this did not translate into emergency use licensing of these vaccines within African countries. So even if the vaccines had arrived in African countries, these countries would not have been able to utilize them because of the bureaucracy that didn't allow them to get emergency use licensing. So that is the first issue. It's only recently that Nigeria has gotten an emergency use licensing for these vaccines, and the DRC is working on getting emergency use licensing for the vaccines to start deploying them. That was the first barrier. Now, with the current outbreak and the Africa CDC's director estimating that they need about 10 million vaccines to respond to this outbreak. The second question is, how do these vaccines now become accessible and available? I mentioned to you Bavarian Nordic is the primary producer of MVA-BN. And it's a small pharmaceutical company. They have the ability to make, they say, up to 2 million doses by the end of 2025. But the pricing point that they have set for a single dose of the vaccine, the subsidized pricing point, is about $80 to $100, which is prohibitively expensive even for African countries who want to purchase the vaccine. And mind you, it is a vaccine that requires 2 doses. So you are effectively talking about $200 for a single individual to be vaccinated. So that becomes a barrier. The US and certain countries in the European Union have pledged a number of vaccine doses from their stockpiles. 500,000 doses here, 100,000 doses there. But again, there's still a gap to be breached in terms of meeting the numbers of vaccine doses that may be required for countries in the African region that are facing outbreaks. Now, you asked about other vaccines. It's a Japanese pharmaceutical company that also has a vaccinia-based vaccine that is effective against Mpox that has been studied in clinical trials. We should be getting the phase 3 study out very soon. And that vaccine has also been authorized for use, but it requires a special needle to be administered subcutaneously, which again may be a barrier to effectively deploy that particular vaccine on a large scale in the context of an outbreak. Now, talking about monkeypox virus-specific vaccines that are in the pipeline, they are leveraging mRNA technology currently, both Pfizer, BioNTech, as well as Moderna, and they have phase 1 studies already published for monkeypox-specific mRNA vaccines. The BioNTech vaccine paper was published, the phase 1 study was published in Cell, and I'll try to find the paper and drop it in the chat for those who are interested. But it was a monkey-based study in which they not only demonstrated that the mRNA vaccine was able to generate a very robust immune response, both cellular and humoral in vaccinated animals, but also protected the animals almost 100% when they were challenged with monkeypox virus. So these vaccines are now moving into human studies. These were all preclinical studies. So they are now moving into phase 1 human studies, phase 2, etc. So one could anticipate that in the next 3 to 5 years, we may be talking about a phase 3 trial of a monkeypox virus-specific vaccine, which is mRNA-based. So that is where we are in terms of vaccines.
Wow,
Yeah,
thank you.
Thank you, Mona, if you permit me to ask, and thanks so much, Buguma, for really, I've learned a lot just by giving that explanation. Let's think about prevention and maybe some epidemic, or I call it pandemic preparedness plan that countries can take. I understand there are also RDTs for monkeypox now available. And some of the RDTs are even nasal swab-based kind of sample collection RDTs. Do you think that countries should make use of the same approach during COVID, for example, at the borders of entry, testing kind of is, to be able to make sure that we are able to put in some surveillance mechanism in place for for case identification, or what's the best approach that countries can actually put in place to make sure that they screen people and prevent transmission? What's your take about that?
Yeah, it is that's a good question, but I would stress that it's not going to be a one-size-fits-all approach, because we are seeing very different factors mediate transmission and virus spread in different localities. And African countries are very different from each other. It's a massive continent. So I think that the response approach would have to be tailored specifically to what each country is experiencing. And I'll take an example. For example, in the Democratic Republic of Congo, again, if you go and you look at the sequences that are being deposited on global databases pertaining to the different outbreaks that are happening in different parts of the country. The DRC is a massive country. Some of those sequences suggest or cluster more with sequences from zoonotic spillover events, whereas some other sequences cluster more with sequences from human to human spread and transmission outbreaks. What this tells you is that there are multiple factors at play explaining the different outbreaks in the DRC currently. Some of the outbreaks are being initiated and triggered by zoonotic spillover events. Others are being initiated, triggered, and sustained by spread between within mining camps, commercial sex workers, overcrowding in hospitals, and these sorts of things. Now, when you think about this variable mechanisms by which different outbreaks are happening, you immediately recognize that the approaches that we use to educate communities about zoonotic spread may not necessarily be those that we use to educate communities about human-to-human spread, primarily in overcrowded settings, etc. So in order to develop a plan that responds to the outbreak within a certain country, coming back to your point about rapid diagnostic testing and testing modalities, you cannot craft an effective response to interrupt an outbreak if you don't understand how the virus is spreading. Right now, even the 17,000 estimated cases that are reported to have happened in the DRC, only 10% of those have been confirmed by PCR testing or other testing modalities. And when you're not testing, you are not effectively contact tracing, and you don't know how your pathogen is spreading. So that should really be the first point, is circumscribing how people are getting it, contact tracing, confirmatory testing, and testing and isolating contacts to understand how the virus is being transmitted. Now, if you start copying and pasting what happened with COVID to say, okay, you're going to screen people at borders, you're going to quarantine people, etc., again, you'll be falling back into that copy and paste scenario when you're dealing with two very different viruses that are spreading in a very different manner. I think that what is more useful at this stage is that one thing that people forget is that for most part, Mpox was still a very rare infection, and many clinicians are not familiar with the disease, how it presents, and what to look out for and how to test for it. So that should really be the focus, educating populations about the fact that there is an ongoing outbreak, educating populations on how it spreads. So we know transmission is close interpersonal contact with people who have an active rash, or sexual contact, or for a very small proportion, and we don't think that this is the primary mechanism of spread, it can also be transmitted through aerosols if you're sharing close quarters with people who are actively infected. Educating the population on how it spreads, how to recognize it, and also providing healthcare providers with the tools to test for it and report it when they suspect cases. I think that these approaches would take us a lot further than starting to put barriers and screening, using resources to screen absolutely everybody at an entry point at a border, when we still know that, even in the other countries where it's been exported, A lot of the countries in Africa are reporting 2 cases, 3 cases. The majority of cases are still in the DRC. So you have to think carefully around how you deploy the resources you do have to really focus them on high yield areas, recognizing it for what it is, being able to test for it, reporting it, and contact tracing.
Thank you very much. I have 2 questions before I open it to the public. And I know we don't want to keep you here for a long period, but my next question is, if I am a doctor in, let's say, in Bamenda or in Bunda, what should I do if I have a case of a monkeypox patient or Mpox patient in front of me? Meaning I want us to go through, and if I also am working at Atlanta CDC, those 2 scenarios, and I'm there and someone comes in and they call an emergency response and they call you over at Emory, what will you do once you have a patient who comes in maybe sick and is having monkeypox? Those 2 scenarios, how do you advise the physician who is back home, who sees this for the first time, he's just out of school? What are the tools he has in terms of what should he do and what treatments are available? What are the things he can do, supportive care and antivirus that are available? That's my first question. The second one would be for Brian, and then I may have Sandrine, who is one of our moderators, ask a few questions, then we'll open it to the public so that we don't keep you here. And thank you very much.
Yes, I would say this. If you have someone who presents to your clinic and they have lesions that make you suspect that, okay, this could be monkeypox or Mpox, the first thing you do is you do have to protect your own self, right? So generally what we've been doing in terms of barrier protection of healthcare workers is gloves and a mask, so a face mask. If you have a surgical mask, that's okay. If you're able to get an N95 respirator, that's ideal. And if you have PPP to cover your skin, sure, go ahead. But generally gloves and an N95 mask are sufficient for you to examine the patient. Secondly, if you examine the patient and you really are worried that this may be a case, you should collect samples. This is a DNA virus. DNA is very stable, very, very stable. So if you have a swab, a sterile swab, swab the lesions that you have, store that sterile swab. You can store it in a -20 refrigerator. Isolate the patient in your health center. So put them in a room where they're not sharing the room with another person. And instruct your healthcare staff to wear PPE when taking care of that patient. And then notify your delegation. Because unfortunately at present in Cameroon, the testing would have to be done at Pasteur, and it would be the delegation of health that would help you transport those samples and get them to Yaoundé to either test and then confirm that you're indeed dealing with a case of Mpox. Generally, what we tell patients is to wear long sleeve clothes that cover their lesions as much as possible. This is just reducing the exposure that their lesions have to the general environment because of the risk of contamination, etc. But it's important to stress that with clade 2B, most people will make a complete recovery within 2 to 4 weeks with just supportive care. And what is the supportive care? Some people have a lot of itchiness of the lesion and pain associated with the lesions. So you can soothe the skin with things like calamine lotion that you use for children with chickenpox who are itching all over. We have those in our pharmacies. Secondly, if they have pain, if they have painful lesions, you can use analgesics to ease the pain. Some people get bacterial superinfection. So be it staph or strep can infect those lesions because they're scratching them. As the lesions heal, they become quite itchy. You treat those bacterial superinfections. And the rest is supportive care, good nutrition, good hydration. Even for clade 1B in the tecovirimat study in the DRC, that study was conducted with everybody who was enrolled into the study was treated in the context, in the setting of a hospital. So they admitted everybody for the purposes of the trial to make sure that they were giving them nutrition and supportive care to the same degree. And in that trial, they found that supportive care and nutrition, so if you take care of people, give them food, hydrate them, make sure you're treating their lesions, it reduced the mortality. The mortality was down to about 1.5% in that study, just from supportive care. That's the biggest message, was that supportive care was sufficient in really reducing the severity and even helping with the recovery. And supportive care that could be provided in the DRC. We're not talking about sophisticated supportive care. We're talking about nutrition, hydration, treating secondary infections. Now, in the people that did die, we don't know yet the granular details of the characteristics of people who ended up dying, in terms of, was this very young children? Were these people who had HIV, which is a risk factor for severe Mpox, particularly if you had untreated, uncontrolled HIV? Was it pregnant women? Because again, we know that there are vulnerable populations for whom this infection is more severe. So when we get additional details on the trial, when it's published, we'll have better characterization of the 1.5% of people who still died despite receiving supportive care. So that is what I would tell a clinician who was dealing with this in a district hospital in Bamenda, and that generally when people have had full recovery and their lesions are fully healed with complete reepithelialization of the lesions, like new skin, healthy skin formed and scabbed over, they are not they're not infectious. Now, I understand that it is not possible to keep someone who in a hospital for 4 weeks or 2 weeks, but you can educate the person on how to isolate themselves at home, wearing long sleeves, using a room on their own, not sharing their utensils with people while they have those active lesions, to minimize the ability or the spread to others who share close quarters with them. And then kind of like answering your question to treatment in terms of antiviral therapies. In the US, we use the drug tecovirimat, which Brian mentioned. It's an antiviral drug that basically targets an important viral protein, Mpox viral protein. We don't know yet its efficacy because it was approved under emergency use licensing in the US using the animal rule, meaning that this is an antiviral drug that was developed and the clinical trials were done using animal models. So animal challenge models, which simply means that you have an animal model, you expose that animal to your virus of interest, you treat with a drug, and you show that that drug is effective in treating. During the outbreak in 2022, it was used extensively under emergency use authorization as an investigative new drug. But unfortunately, by the time we started recruiting people into clinical trials, the peak of the outbreak had passed, so we don't have randomized data to show that it is actually effective against even the clade 2B virus that we were seeing here. But I would caveat it that although it did not show effectiveness in people with Mpox, clade 1 Mpox in the DRC, like any antiviral drug, you get maximal effect when you start early. And monkeypox virus is a virus that has a pretty broad incubation period between 2 to 21 days. Which means that oftentimes by the time you're seeing someone present with a generalized rash, they probably had their prodrome of fevers, chills, and viral prodrome 2 or 3 days before the rash actually appears. And by the time they show up to the hospital, they may be 4 days into their rash, and you're essentially starting the antiviral 1 week after the illness itself started. In that instance, you're not going to see effectiveness for a lot of antiviral drugs. So I know that the results on the tecovirimat trial in the DRC are disappointing, But I urge people to be patient and see the full data when it's published, and also know that there are caveats in terms of who was given the medication. It may actually be that an antiviral drug doesn't matter for someone who is immunocompetent, healthy, and is going to recover from that illness anyways. However, if you have a subset of young children, pregnant people, or people with advanced HIV, starting that antiviral may make the difference between succumbing to the infection and actually having a chance at surviving it.
Wow. I can say if there was any physician who was here who's back home in Cameroon, and you meet monkeypox after this, you will be knowledgeable enough to know what to do. I, coming here, did not know anything about this information. So thank you very much. I have a question before I pass over the mic to Dr. Matt Sandrine, just for a few questions, then we open it to the public. I have one question for Brian. Brian, do you think, I know during COVID pandemic, you did a lot of sequencing, NGS sequencing for COVID, and there are a lot going on now with monkeypox, and we're hearing about the different clades that I'm trying to figure out what it is, the 1, the 2, the A, the Bs, which are interesting. Is this an opportunity for Africa to get into the field of NGS, which is going to affect oncology and virology in the future, and bacteriology and every other thing? Is this an opportunity for Africa to develop this field better? I want to hear your opinion and get also that from Professor Bogoma.
Yeah, I'd love to hear Dr. Bogoma's thoughts on that as well. I think it's a great opportunity. The COVID-19 I think the COVID-19 pandemic led to the establishment of the PGI, the Africa CDC's Pathogen Genomics Institute, that has really deployed bioinformatic capacity across the continent. They've set up regional labs in all 4 regions of the African continent. So in the central region, there's a regional lab. Our Laboratoire National de Santé Publique is part of that network as well. So the need for sequencing and timely sequencing is really important. But we have to, the sequencing has to be done in a timely fashion. It's really critical. There are various things that are very important when it comes to sequencing and using the sequencing data to answer very specific questions. Some of those questions could be epidemiological questions. Some of those questions could be research questions. So sampling is very important. What sampling pool you're taking your samples from and things like that is very important. Dr. Bogoma mentioned that the Mpox is a DNA virus. It's a very stable virus. It has a very large genome. It's close to 200,000 base pairs. So it's about 196,000 base pairs. Different labs are using different strategies to sequence the genome. Some labs are using short reads, Illumina sequencing platforms. Other labs are using what we call the nanopore, which is typically the long read sequencing strategies. It's a very difficult genome to assemble. That I will tell you. And I would say most of the sequencing genomes that have been uploaded in some of the public databases that Dr. Bogoma mentioned, like GISAID and the NIH Gene Bank, the sequencing quality is not optimal. So I think there is a need for us. I think there is a need for much support. As you know, we don't have enough computational capacity in Africa. We don't have the computational capacity to analyze some of the sequencing data. So I think that's one of the biggest challenges. There's a great need to build bioinformatic capacity. It's one thing to collect the sample. It's one thing to sequence the sample. It's one thing to assemble the genome. It's one thing to assemble and perform QCs and QAs on some of those sequencing analysis. So I think there's a really great need for there's a great opportunity there, but I'm impressed so far with some of the work that's going on. There's one person from the NIH who might join this call very shortly, who is supporting some of the sequencing work in the Congo. So I think Dr. Kwe Yinde, I don't know if he's on the call, but I think he's going to. I don't know if Dr. Yinde, you're here, just let us know. But if he's not here, I'll try to ping him and see if he can join us. But he's been working very hard to support some of the sequencing work that's happening in the DRC. He has uploaded some of those sequences on GISAID. already. So I think that to answer your question, I think there's a really great need. There's a great need for sequencing. Without sequencing, we won't know what specific clades we are dealing with. We won't know about the genetic diversity that we're dealing with. We won't know about what some of the drivers, some of the genetic drivers of the disease is and things like that. So I think there's a great need for countries to sequence a lot more so we can, maybe gather more information. But there's not much sequencing can help us in terms of transmission because the DNA virus is very stable. It doesn't mutate a lot. So finding clusters will not mean the same as it meant during the COVID-19 pandemic. So most of the cases will tend to cluster on the same phylogenetic tree, which doesn't really give you much information. It can tell you what clade it is, it can tell you what subclade it is, but it doesn't really tell you if one person gave it to the other person and things like that. So I think that's those are some of my thoughts around that. But the overwhelming number of sequences that are currently available are not of the best quality. So I think there's a great need for countries to there's a great need for support when it comes to sequencing.
Okay, thank you, Brian. And I don't know if Prof. Boguma has something to add. Then I'll hand over to Sandrine. If she has questions, then we'll open it up.
I'll just say that, sequencing is a very powerful tool for surveillance, particularly when you're dealing with viral pathogens or any other pathogen, just to really characterize the types of strains that are circulating, where they're circulating, etc. And there's a huge need to invest and upgrade what we currently have. I think that COVID led to a lot of progress in terms of Africa's ability to do genome sequencing. There has certainly been a lot of growth. There's still room for improvement, room for better computational support. We still have unstable electricity in a lot of countries in Africa. And if you have to talk about that type of computational power, you also have to think about things like having a stable electricity supply and good digital platforms that really allow bioinformaticians to perform at the highest level in terms of their work. And just to kind of highlight how sequencing can very quickly make a difference, when Sweden reported the first imported case of clade 1b, and also when Thailand reported the first imported case of clade 1b in returning travelers to these respective countries, both Sweden and Thailand had the sequences from these patients up on GISAID within 24 hours. And they had identified the virus down to the clade level, right? I can assure you that one thing that we're certainly missing right now is that there's probably clade 1 virus in other countries that's not getting picked up because we ain't doing enough sequencing. We don't know what is being transmitted. And by the time you're identifying a strain of the virus and saying, okay, this is clade 1 that has appeared, for example, in Yaoundé, if you're identifying it 1 month after the virus appeared, that virus is already 100 steps ahead of you. But when you take the example of Thailand, when they identified the clade and they sequenced it within 24 hours and said this was a clade 1b virus, they did contact tracing, identified 40-something people who had been in contact with this returning traveler, and they have instructed those people to isolate and quarantine for 21 days. And they also isolated the case. So that led to a sequence of events that effectively is the response that you hope to see when you identify the introduction of a pathogen into a new environment. And that goes back to my response to the question that was posed earlier with regards to where should we be focusing our resources, should we be screening people at borders, etc. Instead of screening people at borders, you have to build the capacity of, if there's a suspected case, can we test this and get this sequence to know what strain it is within a 48-hour time period, and then tracing to effectively contain it.
Wow, thank you. And since I would love to just thank Elvis, one of our co-moderator and founder for coming. And let's hand over to Dr. Sandrine. Do you have other questions, then we open it to the public.
Okay. Thank you, Dr. Mono. Thank you. This is very, very, very interesting. I learned a lot. So I have two questions. One is I'm just looking back at what happened with COVID-19, the absence of exponential growth and the low mortality in Africa. So we are talking here about something which is not as, I would say, widely spread as COVID has been, at least in the African continent. So I'm wondering if the sequencing measure that we are talking about, is it really the way to go for Africa? Particularly, I would expect it to be even harder to convince people to go for vaccination, even if those vaccines were available. That's the first question I have. How should we educate the population, knowing that they already have this experience of COVID-19 spreading and not impacting us much as one would have expected. So that's one. And the second piece is really regarding how do we actually work with what we have in Africa? So what I understood from the speaker was that if they just get supportive care, it can actually make a difference in the mortality. So I'm just wondering if the effort right now should not be on educating physicians and family on how to properly take care of a patient who's infected, rather than trying to get the sequencing. I think the sequencing is important, but given the context, what should be prioritized? I think if the Minister of Health was here, maybe he will give us more insight, but we'd love to hear the speaker on those aspects. So thank you.
Oh, you're muted. Well, let's.
I think I think you raised very good points, and I would just clarify that I'm not saying that all resources should be turned completely to do sequencing. Sequencing is nice and important to have as part of pandemic preparedness and disease surveillance, not just pertaining to Mpox, pertaining to all infectious pathogens. When you sequence, you understand how diseases are changing, how they're moving and impacting populations, and you are able to identify new emerging variants of a particular pathogen more quickly. So there are many benefits to sequencing and upgrading and developing the African capacities for sequencing. There's only benefits to be had from that. Now, particularly pertaining to the response to Mpox, you're completely right that it is behaving it's a very different virus from COVID. It's not as infectious as other viruses when you think about, for example, the R0 number in terms of how many people can one infected person go on to pass a virus to. For example, if you take the case of measles virus, the R0 number is anywhere between 12 and 16. So one person who is infectious from measles can go on to infect 12 to 16 other people who are susceptible to measles and have never had it or have never been vaccinated. For COVID, the R0 number was anywhere between 2 and 3. So if someone had COVID, they can pass it on to infect 2 or 3 other people. For Mpox, the R0 number is slightly less than 1. At least that was the case for clade 2B virus, and also explains why it was so easy to get this virus contained through communication and education when we saw cases here in the US, and through vaccination, because it was spreading primarily in sexual networks and social networks of a particular group of vulnerable people. And behavior change actually within that group is thought to have contributed a lot more to containment than vaccination itself. Vaccination helped, but it was really behavior change, because again, that virus has quite a lower R0 number compared to other pathogens, which are a lot more infectious. So I had already said that in terms of the response, our money is most well spent by educating both clinicians to be able to recognize this, test, confirm, contain, and educating the population on what it is, how it's spreading, and to have an awareness of this. And to address the third and final point, again, when we talk about vaccine access for Mpox in Africa, I think that a key part of the conversation around vaccine access should also be around vaccination strategy. So who do you vaccinate? How do you vaccinate? What makes the most sense? Does it make sense to introduce this in a national immunization program? Probably not, because it's not spreading, for example, like measles or polio. Does it make sense to vaccinate close contacts of someone who is infected through a ring vaccination strategy? Maybe that's a better approach. So these are all conversations that need to be had at the level of individual countries based on their risk stratification of what Mpox represents in terms of risk for its broad population. And that way, you can target the resources towards those strategies that have the highest yield. Again, I caution against copying the strategy from one country and pasting it in another, because the outbreaks are not the same in each individual country.
Wow, thank you very much. And I would open the floor. We have about 30 minutes of questions and answers. Those who have questions, you can raise your hand. And we are privileged to have experts, and one of the best expert I know privately who understands Mpox. So if you have questions, you can just raise your hand. And Elvis, do you have any other questions that you had or things you wanted to?
Well, no, I just wanted to just follow up again still to my question, because I think when Professor Bukuma mentioned about when as a clinician, you asked a very important question as a clinician, what will you do? And she talked about sample collection, sample storage, and maybe the chain of custody for the sample management of sample. The question is, are there other low-level testing that could even just help, like eliminate what sample you send forward? Does RDT help? That's what I wanted to find out.
Actually, some of the work we did here at Emory during the outbreak in 2022 was we validated a Cepheid-based rapid diagnostic point-of-care test for clade 2B virus. And that Cepheid test, that validation was done using samples from Mpox collected in patients here in Atlanta. And it led to that Cepheid cartridge test being approved by the FDA. The reason why I particularly mentioned this particular validation platform is because Cepheid testing is available in literally every country in sub-Saharan Africa, because it's also the platform that is used to rapidly diagnose MTB, tuberculosis. So it's now the standard of diagnosis for Mycobacterium tuberculosis, and the WHO has approved that testing platform, and you have that Cepheid machine present in basically every provincial level hospital will have Cepheid TB testing available. The benefit of having a rapid diagnostic test that can be utilized on a platform that is already available with the machines available in a lot of countries means that all you need to do is now get the cartridges for that test to be run using that machine that already exists. I use Cepheid as one example. Currently, there are other antigen-based testing like lateral flow assays being developed. A lot of these tests are limited by the fact that whenever you develop a test, you need to validate it on clinical samples. So you may see a test on the market, but you don't necessarily know if it's been validated to effectively detect the particular form of the pathogen that is circulating. I'll take the example of clade 1B, which is the new emergent clade of the virus that has emerged in the DRC. The virus, the clade 1 virus, has deletions in some of the genes that are used as targets for the common PCRs to detect Mpox. And that if you use some of those commonly available PCR techniques, you may miss detection of clade 1B virus due to those deletions in that particular gene target. That is why validation is important. So we validated the Cepheid platform for clade 2B, and that test is approved. But to be able to have the same for clade 1A and clade 1B, you would have to also go through the same validation process and get approval for these tests so that they can be widely deployed. And I think that in the strategic response plan that has been put out by both Africa CDC and the WHO, there's a particular axis that focuses on the need for developing rapid point of care diagnosis. And, you know, in a dream world, what we want is assays similar to lateral flow assays like what we had for COVID, where you can go to your doctor's office, he sees a lesion on you that looks like Mpox, swabs it, puts it into a lateral flow assay, and you get a yes/no answer in 5 minutes. We are not there yet, but I'm hoping that one of the things that the public health emergency of international concern will help support is really the resources to accelerate a lot of these testing kits and get them readily available to countries that are dealing with an Mpox response currently.
While waiting for others who have questions, let me follow up with, since others are not putting up their hands, if we have these vaccines now, WHO said we need about 10 million. If we have these vaccines, whom should we give to? I know here when we had the Mpox, we had populations that was high at-risk populations that we could vaccinate, men who have sex with men and those were the populations. But now in Africa, what population should we target? If we say, I have 20 million vaccines coming into Africa, whom should I give it to?
Risk stratification, who is getting Mpox in your country, should dictate what your country's approach should be to vaccination. I'll take the example again of the DRC, where we are seeing a lot of more severe disease in very young children. It may make sense to do ring vaccination so that if you have a child who's an adult who is infected, you vaccinate the members of the household, including the children within that household. This is just an example. I'm not saying that this is the strategy that they would adopt, but I think that it's very important to tailor the vaccination strategy to respond to the outbreak that you are dealing with. If you have an outbreak that is primarily impacting commercial sex workers, it may make sense to prioritize these groups when you are actually deploying a vaccine. But there are other considerations that are important as well. Remember that when you start also defining groups that you are targeting for vaccination, there's always the risk of stigma. So the last thing that we want is also to now say, oh, this is only spreading in commercial sex workers, and these are the people that should be vaccinated, because then if someone sees you lined up to get an Mpox vaccine, the immediate thought may be you are a commercial sex worker, and that's why you're going to get the Mpox vaccine. So I think that a lot of public health agencies and the ministries of health are thinking very carefully through these particular concerns. How do we deploy it in a manner where it has the most impact in protecting those we're seeing affected by the infection? And how do we do this in a manner that doesn't increase stigmatization of certain communities? One thing that I would say is that it makes sense, for example, if you're having issues with outbreaks happening in healthcare facilities due to overcrowding and lack of PPE to healthcare professionals, it makes sense to provide immunization to frontline workers who are responding to this. And then the rest of the conversation and how you prioritize and identify vulnerable groups and differentially offer these vaccinations to them would really be done and should really be done at the country level in response to the characteristics of the outbreak at hand.
Oh, thank you. I would call on, please be brief with your questions, and we go straight to the point. I'll call on Franklin Maloba, please, you can. Oh,
yeah, maybe before Franklin, please, Franklin, just excuse me, just a follow-up to Bogoma. I remember when in 2022, I think I wrote a paper that stayed in on my computer, and I think the caption of my paper was, the sick criminal, which was about, how our laws at that time, because I think the conversation was that the population at risk were men having sex with men. Then I looked at all the countries that, have homosexuality as a crime, and I studied all the data from that country on the number of homosexual people in each country, and the percentage was really staggering. Then I now kind of coined my paper on how do you balance between morality and law. And the whole issue was, so if I'm sick, if you were to have vaccine and you clearly science shows that you should vaccinate those men having sex with men in a country where that is illegal, how do you even start that conversation? How do you even, as a public health agency, navigate through something that is so illegal? Then, then it brought the moral question about how do you legislate what is morally, correct to do. So I think I'll revisit that paper and share with Bogoma, but I'm just sharing some thoughts about morality and legality.
And thanks for sharing that, Elvis. And you raise very, very great points, which is again why I say that, governments, as they get these vaccines, particularly in the countries that are seeing the highest case numbers, have to think very carefully about how they balance their laws, their country's laws that may stigmatize some of those very populations that they want to vaccinate, with protecting people who are vulnerable to an infection, and also with the priority of trying to effectively stop an outbreak that is continuing to grow. And I have said this several times again in the 45 minutes that we've been on this call, that a copy and paste approach never works. You have to adapt the way you respond to an outbreak based on the local factors of where that outbreak is happening. And it makes, in my opinion, one of the approaches that to me would be less stigmatizing would be to adopt a ring vaccination approach, in which you're essentially vaccinating close contacts of the person, of whoever is found to have an active Mpox infection. That way, you're not dictating criteria for vaccination based on, this person may be a commercial sex worker or maybe a man who has sex with men. You are basically dictating it on this person is a close contact of someone who has Mpox and as such may be more exposed to it than others who are not close contact to that person. If you pitch it in this way, it makes it more accessible, more acceptable, particularly if you focus the sensitization on the fact that vaccination may prevent the person who is exposed from getting Mpox, or if they do get it, it would be an attenuated form of the disease.
Franklin, take over with your question. Please be brief.
Yeah, thank you very much, Dr. Mono, for this opportunity. And thanks the Town Hall for bringing this pertinent topic today. Yeah, my first question is, with this Mpox stuff, based on COVID experience, a lot of people still panic. And the point is, we don't know how prepared Africa is, especially, let me say, Cameroon and Congo. If this turned out to be a pandemic, how well is Cameroon prepared to handle such for the people not to be panicked? That's the first question. Secondly, in terms of capacity building, many people are not even aware. They just hear Mpox. Most of the health facilities do not even know if these things exist. In terms of capacity building, I don't know if is Dr. Brianda will answer this. How is CDC doing to ensure that the big capacity, especially for those in royal setting who are closer to the forest and maybe closer to the animals, or maybe they can be exposed without knowing? And finally, and the most important question is that, with the crisis back home, a lot of people are living now close to the villages, forests, and that some of them even don't have potable water, which they can have or develop other rashes. And some of the health personnel may not know how to distinguish between these rashes, if it's caused by maybe due to unhygienic situation, or maybe caused by Mpox, and maybe this is co-reopening. And maybe some of these children present with that, it can cause a lot of panic. What do you think can be done in that situation to handle it and to reduce the panic among the population? Thank you.
I think that you raise very, very valid points. And again, a full disclaimer, I don't work for the Ministry of Health, so I can't comment on what whatever strategic plans are ongoing in Cameroon's Ministry of Health to prepare for the response to this outbreak. But I'm sure that they're thinking about it and that they have a preparedness plan. When you talk about CDC in the US building capacity, I think that the question of building capacity to respond to outbreaks and pandemics and health situations within a country, that responsibility primarily lies first and foremost on that country's government to prioritize funding healthcare, funding research, and funding preparedness to respond to disease outbreaks. Unfortunately, what we have often seen with outbreaks of infectious diseases on the African continent is that many African continents continue to have a stance that is overly reliant on foreign donors being able to give us vaccines and give us tools to test for this. And we've seen this strategy fail us time and again. This is the second public health emergency of international concern being declared for Mpox. We had one declared in 2022 that didn't lead to or translate to increased testing modalities in African countries or increased access to vaccinations in African countries. And one can argue that that was because countries in the global north hoarded the resources or refused to share them. But I think that it makes it harder and harder to constantly expect that others would be more pressed to respond to our own issues than our own governments themselves. Most countries in Africa invest less than 1% of their GDP to health and research. And I think that that is where the problem really lies. So we can't be waiting for Africa CDC or a Bill Gates funded grant or America CDC to be the ones that brings the resources to come and address the problem that we are currently facing. And to your point of the high risk for zoonotic transmissions, outbreaks in schools, how clinicians should differentiate, that goes back to the point I've already made multiple times, is that the key pillar of the response at this stage, particularly for countries like Cameroon, should be educating the population of the fact that there are outbreaks happening in neighboring countries and educating healthcare professionals on how to recognize the disease for what it is, know how to collect samples, and where to send these samples for testing. And that is what should be part of the ministry's strategic plan in preparing to respond to this outbreak. And I'll stop there and leave others opportunity to comment.
With such a pertinent topic, please, in hand, I don't know if Dr. Mono tried to contact anyone from the ministry to see if they can give us an input, because I think that a lot of people panic in most of my WhatsApp group and they were asking me, like, what is the way forward? Dr. Mono, is there any contact from the ministry with such a pertinent topic from the town hall where we know that the minister is always here? I don't know if they sent any representative. Thank you.
Yeah, this was of short notice. So right now there was no one from the ministry, and if there is any update and if Cameroon has a strategy, we'll figure out and try to get someone to represent. So in the future. Next question, we're calling on Simon Joyer. Please, you can go ahead with your questions, please.
Well, thank you very much for the opportunity. I wish to ask Prof. She talked about the smallpox vaccine conferring immunity, and I wish to find out if when she talked about the strategy, she mentioned she insists on a ring strategy of vaccination. Would it be important to target a set of population that were born after the 80s, like she mentioned during her expose, the set of population that were born after the 80s, and increase the vaccination to that particular set of population so that we can attenuate the way in the virus in an eventuality of an outbreak? That's my question. Thank you.
Yes, thanks, Simon, for your question. I think that these are all debates and conversations that have been happening not only in the context of the current outbreak of Mpox and the current public health emergency. These conversations on whether there is a role to reintroduce smallpox vaccinations on a broader scale to protect vulnerable populations from Mpox and other orthopox viruses is a conversation that has been ongoing. But I must remind us all that we are currently navigating, conversations around vaccines in the context of lots of misinformation and public mistrust, particularly within the African continent where vaccines are concerned. And this has meant that a lot of public health agencies and public health leadership within the continent has to be very, very strategic and thoughtful in how they contemplate introducing new vaccines on a broad scale within populations. Besides the angle or the concern for misinformation and hesitancy towards vaccines, there's also the facet of added cost, right? For example, take Cameroon, a country whose population is currently estimated to be about 26, 25 million people. In the past year, they've maybe had 35 cases of Mpox, according to the WHO tracker. There were outbreaks in Kumba, and there were 2 outbreaks in the Southwest amongst, I think, internally displaced people in 2023. Does it make sense for the Public Health Ministry in Cameroon to put an investment of this an arbitrary number, 40 million Cameroonian CFA, to vaccinate everyone born after 1980 against smallpox when we are having 35 cases of an orthopox virus infection a year? In that situation, it may not make sense, particularly when you consider that they still have to pay for childhood immunizations of diseases that are having a much more significant impact on the population at the time T compared to something that may be an epidemic threat for the future. So there's a lot of factors that have to be considered when you think about immunization strategy. And I don't think that there is a single recommendation, which would be, broadly speaking, let's just go into a country and vaccinate everybody for this infection, which may not yet represent a significant public health burden for that particular country. Bringing me back to the importance of really tailoring strategies based on risk stratification of what is happening in the country at that time, and also thinking carefully about vaccination strategies that would not stigmatize a particular group of the population, will not feed into misinformation and disinformation, and will still respond to the outbreak or the threat of the outbreak without financially crippling the country and shifting priorities from other public health emergencies.
Thank you very much. And I think the last hand up is Dr. Bunda, whose hand is up. Do you have any question, please?
Yes, thank you for a great presentation. I am Dr. Buna from Yaoundé.
Tu peux parler en français. So I think we lost him, and I hope I read one of his questions. I think it was not, one of the questions was not on the topic, was on the topic of sickle cell, which is something I can address later if need be, or I can address it right now. I don't know if that was a question he wanted to ask, but that's not what we're discussing about today. But gene therapy in sickle cell, just for us not to, is something which is still very expensive. It's about $3 million, even in the US. And we have 2 technologies that are available right now. There is, as he said there, the CRISPR technology and the lentivirus editing technology. Even in the US, it's not yet affordable for the kids who really need it. And we need to get it affordable. We need a lot of financing, and Africa is not yet ready for that to be scaled up. So we don't even have the platforms to do that scaled up in Africa. So it's going to be a discussion for some other town hall, but I don't think we are there yet. Back to sickle cell, we should go back to the basis, get children vaccinated, get ourselves screen, get premarital screening. Education is key. Once people are already having sickle cell, we should think about making sure they have their folic acid, hydroxyurea, getting access to new therapies. These are all the things we'll talk about, but gene therapy is still a long way ahead. There's even no chance for bone marrow transplant in most places in Africa, apart from South Africa, Nigeria, and the northern countries in Africa. So we're still far away. So not wanting to take much from this topic, let's go over to, I see a hand up, Atanga. You can unmute yourself, Anya.
Thank you. Thank you very much, Dr. Foma, and thanks for the session. It has been really wonderful. I think I worked closely with Seple in the Southwest region when I used to work with Boya Health District, and I think they are doing a lot in terms of monkeypox surveillance. I just got to Dr. Agwe, who is the head of Seple, to let him know if he can connect to give an updated information of what the Southwest region has been doing so far. I think that's it, and thank you. Over.
Thank you very much. I think we are almost an hour, 45 minutes. I would love to give the last words to those who voluntarily came in. I was planning on contacting Professor Boguma Titenji because I know she's a key knowledge bank when it comes to infectious disease. Her background, for those who don't know her, she's a virologist, PhD. She's an internist, and she's also an infectious disease, and she's a physician scientist at Emory. Trained in Cameroon, knows Cameroon very well, and also knows how things work in Europe and in the UK, and has a big background on infectious disease in Atlanta, where she works right now with Emory. And she's a professor teaching and also trying to train young physicians in the US. And I think she is a wealth of knowledge that those back home should use. I will always say this, those back home, you have people, those who are professors in our universities, those who are our lecturers back in our different medical school, you need to take advantage of people like this. And I'm happy she always joins, sacrifices her time and knowledge. I would love to get a last word from her, a take-home message. And we know the platform is always open. She knows that very well. To her in particular, a last take-home message for the patients who may have monkeypox in the future, or those who have had it, and for the physician who is sitting there, who is a GP trained and is going to panic during their first. I know you answered this already, but what is your last message to us and to the Cameroon government and everyone and Africa overall?
Thanks, Muna. I think that a simple way of summarizing everything, if you're to leave here with anything, is knowledge is power. Inform yourself. Don't rely on hearsay. There are resources that are available. And when I finish making these statements, I'll try to very quickly drop some of those online. I think that the WHO has just put out on their website a tracker for the ongoing outbreak that has key summarized information on Mpox, what it is, how it presents. If you're a clinician, do yourself that service, go online and read and inform yourself about the disease and how it spreads. Because I think that it is only by informing ourselves that as public health and medical professionals, can we then educate our communities and really help protect people from the misinformation that is spreading? Now, the commentary I'm going to make more sort of broadly with regards to the outbreak that's affecting Africa currently is that Mpox has been around on the African continent for the past 4 decades, or almost 5 decades. First identified as a human disease in 1972. So it's been more than 5 decades. And we've only seen it grow over the 5 decades that this disease has been present in human populations. Much like with any other pathogen that you can think of, they do not magically disappear without a concerted effort to really stop them in their tracks and make sure that we contain these diseases from becoming a more significant pathogen. Relying too much on external support to kind of always come and address our own problems would remain our Achilles heel until we are able to really learn to advocate that our own leaders take the initiative to invest in health, invest in surveillance, particularly on those diseases that disproportionately impact our populations. So the story of Mpox is still being written in Africa. And what I hope for is that we would learn or finally learn the lessons from this current public health emergency of international concern. I was heartened to see the president of the DRC pledge $10 million from his government as part of the support in response to the outbreak within that country. And I'm hoping that more countries and more leaders, African leaders, would follow suit in the same manner. Because until we start taking our problems seriously, we cannot continue to lay blame on others for not taking our own problems seriously. So inform yourselves, keep abreast, and know what's happening with the outbreak. If you inform yourselves, you're better armed to inform others within your community. And with that, I would stop. I thank again, Muna. I always like to come on because I don't like to see misinformation spread. And I think that one of the big things that the town hall has done is to continue being a beacon of evidence-based information of health professionals in Cameroon. And I think that there's nothing more precious than being empowered by knowing the right information. So I'm hoping that anyone who has attended this session would also then go into their own communities and networks and amplify the right messaging around this outbreak. Thank you.
Wow, thank you very much. And thank you for your commitment and for always being willing to share your knowledge with us. I would like to get my co-moderators, just call on them. Then I would say 1 or 2 people who are here who can pass across the message. So Brian and Dr. Matt Sandrine, one last words.
No, thanks a lot, Mano. I don't think I have anything else to add to what Dr. Buguma has shared today. I think this was a very enriching session.
Well, thank you. And any last words from our co-moderator, Dr. Sandrine?
I think this session was fantastic. I really like how Dr. Bogoma actually walked us to the evidence. Et j'espère que les gens qui écoutent, les francophones comme les anglophones aussi, pourront aller chacun dans sa communauté et parler de ceci. Je voudrais juste parler que chacun de nous, on peut faire une part. Pour les médecins qui sont au Cameroun, éduquer, continuer à éduquer et puis partager ce qui a été partagé aujourd'hui dans nos communautés. Merci.
Okay, thank you. And I see the director of the regional hospital is here, Dr. Dennis, and I'm happy you attended the session. Do you have a word to say? And I will give the mic, the last words also for Professor Mafobi. Dr. Dennis. Okay, no more. And I don't see Prof. Fobi around anymore. So thank you, everyone. It was a pleasure having you all here. And special thanks this was last minute. As we said, we were supposed to have the Minister of Public Health in the last 2 sessions. And not of his making, I don't want to give excuses, but during the first session, the minister could not make it as a result of not being able to fly back to his office for the session. And now we have an emergency in Africa, which is very occupied. So we're looking forward to our next session in 2 weeks, where we will discuss some other public health of interest or some other disease of interest in Cameroon, and we'll get a speaker. If the minister is ready, then we'll let everyone know, and we're going to publicize that. And see you guys in 2 weeks. There is no parking lot session today. And please have a wonderful day and enjoy the rest of your Saturday wherever you are. Thank you.
Yeah, thank you all. Thank you very much.